Olá, boa tarde. Sejam bem-vindos à sessão da ESSKA-ESMA, agradecendo desde já o convite da SPOT para estar presente. Thank you very much to our friends, invited friends from Spain and Netherlands. Two people that you know for sure. Juan Carlos Monlao is a great friend, a great professional, and also Thomas Pat, also a great friend and a great professional. I think they would give you nice lectures. And also my good friend Elder Pereira, that is going to begin the first lecture. Elder é especialista em ortopedia e traumatologia, ex-membro do board da ESSKA, ex-presidente da AFAS-ESSKA, past president da Basic Science Research Committee da ESSKA, membro do Comitê de Perna, Tornozelo e Pé, membro da direção da SPAT, enfim, entre muitos outros projetos que têm dignificado a ortopedia nacional e, sobretudo, a Sociedade Portuguesa de Artroscopia e os membros do joelho e tornozelo a nível do nosso país. Obrigado, Helder.
Good afternoon. For reasons of this being an international panel, it was decided by the organization that we'll all speak in English. Desculpem, mas it's a pleasure and an honor to be here. Thank you, Enrique, for the kind words. And we will share in the coming minutes some concepts about medial collateral ligaments in surgery and injury and its role in the athletic populations. We will try to organize the talk from the basics, the principles of treatment in athletes, and some of the current controversies, repair, uses of technology like internal braces or reconstructions. Coming from the basics, when we are talking about the MCL, we must consider in layer 2, the superficial MCL, and the deep layer 3, the deep MCL with its meniscofemoral and meniscotibial ligaments. But we should also consider that this is a more complex and broader structure with more static stabilizers, mainly the posterior oblique ligament with its role in rotational control besides valgus control, and also the posterior capsule and oblique popliteal ligament, as well as the known dynamic stabilizers, because when injured, they are also risk factors for treatment and return to play. The superficial MCL, we all know, it's the main resistance for valgus stretch, and mainly between 20 and 30 degrees of flexion, but also plays a role in restraint of AP, translation of the tibia, and rotation. The deep MCL plays a higher role in full knee extension. I bring here, which is linked to the principles of treatment, also the relevance of the POL, because besides playing a role in control of valgus, it also plays a role in rotational control of the knee, as we will hear about. Most of these injuries are contact injuries. It's the more common injury mechanism is a contact injury with a bit in the lateral compartment of the knee, with about 70% of cases. And this is linked mostly to higher grade injuries when compared with non-contact injury, which are more frequent in female, probably because of the anatomy and the Q angle that we know from ladies, and also in sports that require repetitive valgus stress. And this is the fact that probably makes it a little bit higher in such sports, that this mechanism is different in terms of injury. But more often, these are low-grade injuries. One thing that we must consider, particularly if we will talk about the decisions for treatment, is the combined injuries, because it's completely different if we are talking about an isolated MCL or the most frequent multi-ligament injury of the knee is the combination of ACL tear with an MCL tear. And this is a pattern that obviously, because of the ACL, we will go for surgery. So this will make our decision of treatment a little bit more complicated. The same thing about the meniscus. Mostly the posterior horn of the medial meniscus, which is also related to some degree, like we have heard of peripheral lesions that might play a role also on rotational control and as a risk factor for ACL reconstruction. A little bit besides the scope of this presentation, but still chronic cases might develop calcifications, this Pellegrini-Stieda syndrome. As we were talking, these combined lesions do play a role, and sometimes we have surprises if we don't suspect things in advance. Meaning, in the presence of a patient with an ACL tear with clinic compatible of medial pain, we must double check for an MCL injury. We will see that we cannot always rely on exams, and our level of suspicion is very key to success in terms of diagnosis and treatment. Deep MCL injuries are not easy to evaluate also in the clinical setting, occurring combined with ACL ruptures. These are linked to higher rate of posterior medial meniscus tears, and this might be a risk factor for late failure of reconstructions. And all this we need to suspect because it will not be written on the patient's face. The clinical evaluation must be done always in full extension and 30 degrees of flexion for the reasons that we just spoke, and trying to use a classification of injuries from not disorganization of the tissue in a grade 1, for a partial tear on grade 2, and also a full tear, a complete tear with complete disorganization of the MCL in grade 3, but always link this with the amount of joint laxity evaluation and in grades 1 to 3 also. So the advice is always to combine this assessment. As we just said, we always make standard X-ray evaluations for any knee injury. Stress X-rays is something that we don't use, particularly in the acute, but it's not something that we use regularly. But check that the MRI evaluation has a sensitivity of only about 70%, because it's not always easy to diagnose these injuries, particularly in the acute phase of combined lesions. So we must combine our clinical assessment, patient's complaint, and imaging. And this is particularly in the field of combined lesions, it's not always easy. So we must suspicious in advance. And once more, it's a combination of all this that will make us come to something that might be linked to a prediction of outcome and a decision for treatment, or at least guidance for treatment options. We did a review a few years ago related to football, and in which there was some agreement that conservative treatment was the choice for grades 1 and 2 MCL lesions, either isolated or combined. But there was a trend, particularly in combined lesions, that grade 2, relevant, important injuries, grade 2, combined with ACL tears, might develop some residual laxity in future, and some authors were changing to a more aggressive treatment and a combined repair or some sort of act. And some agreement that grade 3 injuries would require often surgical treatment. Excellent outcomes for either MCL direct repair or repair plus graft augmentation, or in selected cases that we'll speak about, the reconstruction. So, treatment. long immobilization is something that it's bad for our biology. Our collagen, our ligaments don't like too much of immobilization. So as soon as possible, the key is early range of motion when tolerated, probably protected with an hinge brace, and the use of injections with, and I'm a guy from the tissue engineering field, the use of PRP or other substance, it's something that there is no evidence supporting it systematically at this point. Repair. Repair has been proven to be effective. Repair has been proven to be effective, particularly in the acute setting, and also if we are talking about the proximal injury, which is more prone to heal. This is the easiest part, and traditionally we have done it with suture anchors. Now we have better tools to do it, but the main principle is direct repair of the proximal fibers when suitable. A little bit more complicated for mid-substance tears and more complicated even in distal tears. So it's something that probably, at least isolated, it's not the best choice for chronic injuries. So the timing of surgery is key to success and patient selection is crucial. Something that is for later debate, it's the use of the internal blades. I'm a biology guy. I don't like synthetics, but I must admit that I've been using this in many cases because it's very easy, and particularly in the acute setting, when surgery is performed before at least until 3 weeks after injury, and mainly in this combined surgery ACL, MCL. It's very low aggressive, and it's like making a suture, but without requiring the opening of the medial compartment and being less aggressive, keeping the biology, and using this tape that we can use. It will protect the ligament while it heals. It's not meant to replace the ligament, it's only to protect it while it heals. And you see that after this we can go for our regular rehabilitation protocol without any protection of the medial compartment. Reconstruction. You can reconstruct the MCL isolated, the POL isolated, the MCL plus POL. There are several reported techniques. This is something that obviously, once more, we must adjust to the patient's requirement. In my hands, this is reserved for high-grade injuries and chronic cases. In all chronic cases, I tend to go for reconstructions, and most of the reconstructions will be the combination of MCL, POL in my hands. Repair, we have heard, it's not a good choice in the acute setting for many reasons, because of the biological capacity of the tissue itself, because it's not easy to identify the structures that have just been disabled, and they are now difficult to identify for repair. And this multi-ligament, if there is a combination of ACL, PCL, and MCL, for sure, reconstruction in my hands, it's the choice. I use usually the modification that I've learned from Bertrand. You see that sometimes it's necessary, and we can identify even the saphenous nerve during the procedure, and good outcomes have been reported. You see the first arm, it's the superficial, tends to repair the superficial MCL, and afterwards the POL arm, which will be passed through a tunnel through the tibia up to the front and tensioned. My good friend Martin Lind has studied a lot on this topic, and for sure this type of reconstruction it has good outcome in chronic cases. And one thing that he also showed is that besides this MCL reconstruction provides good outcome in the mid to long term, and control of medial laxity. In combined ACL, MCL injuries, there is a trend towards lower outcome, worse results in this reconstruction of MCL plus ACL when compared to ACL reconstruction alone, probably because these are more complicated cases. But if we revise the literature, we can't still prove enough that there is a major difference between repair and reconstruction, probably because we cannot assess that well the role of the role of rotational control arising from the reconstruction technique. But a high rate of return to sports recreational return to sports is to be expected, but not always to the same level when patient requires, particularly in these combined lesions. Often they do not return to the same level, and this is something to tell the patients. So as take-home messages, MCL tears, most common ligament injuries of the knee. Most of them will be low-grade and they will heal with conservative treatment in around up to 6 weeks. But some cases requiring reconstructions for control of massive and nasty injuries or combination of ACL, PCL, and MCL injuries, it can take about 6 months to recover from the MCL injury alone. Timing and tissue quality are factors to take into consideration for decision of treatment. There is a role for direct repair, mainly in the proximal lesions. And if there is a distal lesion, I will always add some graft augmentation using at least the gracilis. Probably internal bracing here might play a role, let's see, in the mid to long term. MCL, POL plays a role in providing higher rotational control on these constructs. And we cannot state, and I don't believe there is today a close algorithm for the treatment of these injuries. So you make your own line of thought, your own line of evaluation and decision, and please share with us because we need to learn a lot in this field. I hope to see you all very briefly in the specialty days of ESSKA and the upcoming Congress in Milano. Thank you.
Thank you. Obrigado, Helder, pela excelente didática exposição. Convidava agora o professor Juan Carlos Monlau, orthopedic surgeon, knee surgeon and sports traumatology, head of the Department of Orthopedic Surgery, Hospital Universitário del Mar, Barcelona, ESSKA first vice president and future ESSKA president next year, past president of AAA, full professor of orthopedic surgery, and member of several societies and associations. So it's a pleasure to have you with us, and thank you again for coming to Portugal.
Thank you, Enrique, for your kind words. I wasn't aware having such a big CV. Good afternoon. It's a pleasure for me to be here again. I would like to talk about the added value of the lateral exarticular tenodesis to the ACL reconstruction. Here, this is my disclosure. And if you look at this picture, this is the Lieutenant Commandant or Lieutenant Colonel Haygroves in his early 1917, so back in the last century, doing his ACL reconstruction, very nice reconstruction. If you look with more detail, you can see that the reconstruction is pretty much the same as we aim to do today. So we are, again, back to the future. However, this type of reconstruction that had been refined over time ends up with 70 to 90% in the best series of satisfactory outcomes, meaning that the patient is functionally stable, the patient has no symptoms, and the patient can return to play or return to the sports of his activity level. Meaning that at least between 10 to 20%, they have some problems. 20%, in fact, with remaining pivot shift, high retired tears in some patients, and revision cases in most of them with high grade of laxity or instability, meaning that we are getting closer but not perfect when we reconstruct the ACL. If you look at the biomechanics of the knee, the ACL, when it is torn, gives some type of instability. One is the exaggerated or increased AP motion, and the other one is the rotatory instability. In terms of AP motion, the ACL is able to restrict 70% of this movement, not 100%, 70%. But if you look at the rotational stability, when we cut the ACL, 10 to 25% increase the rotatory instability. Again, not 100%, meaning that some other structures, it has been nicely described in this paper, particularly the lateral structure, contribute a lot in this rotational stress. So in terms of rotational restraint, the anterolateral structures are really important. Back in the last century, in 1960, this guy, Marcel Lemaire, in that time where the intra-articular reconstruction of the ACL were far from perfect, designed this technique, this nice technique, working on the lateral side, just to control the rotational motion of the knee in this lady. It was a dancer, a ballet dancer, that has an ACL torn and was unable to play again. After the surgery, she was able to return to his former practice. The idea was so good that many people engages with this idea. This, by the way, is Ron Losey, that either reproduced the technique and also state a new, paradox. They call the wagon wheel paradox, stating that the brakes in a wheel wagon should be in the periphery, not in the axle, meaning that if you put the brakes on the periphery, they will be much more efficient in braking the wagon as it moves. So this idea was refined by some other authors, and they developed new techniques to do exactly or to reproduce exactly the same principle as Marcel Lemaire. So any kind of reconstruction. It was in the 70s of the last century. However, and they relate this due to the arrival of the arthroscopic surgery and due mainly to this guy, Bill Clancy, we were able to reconstruct much more properly, much more adequate, much more anatomic the ACL. And so the technique changed a lot. And then Marcel Lemaire passed to be the good guy of the film, to be the ugly face of this story. Then as time goes by, in 2013, this new ligament was discovered by these guys from Belgium, not far away from your home, Thomas. However, interestingly enough, 1 year before, this group of French guys described the very same ligament, meaning that nothing is new in medicine. We just repeat and repeat the same story again. This is the nice ligament that Philippe Neret and his group described, that is exactly the same that the guys rediscovered the year after. Well, what is the meaning of this extra-articular reconstruction? Of course, we aim to reduce the anterior-posterior motion, meaning the anterior drawer. We aim to reduce the pivot shift, this rotational motion of the lateral condyle or the tibial plateau, more properly. And we aim to reduce the internal rotation of the tibia. So if we are able to control all the three things, probably we get it. What we can do it? Well, the classical method is to do the Lemaire or modified Lemaire procedure, or more recently, they developed this technique they call the ALL reconstruction, anterolateral ligament reconstruction. What is my preference? Of course, if you look at the anatomy and you look at the biomechanics, as in this nice study from the group of Andrew Amis, Chris Kittle was the first author. If you look at all the structure of the lateral side of the knee, the superficial and deep iliotibial tract are the most prominent in restricting this rotational motion, while the ALL, as you will see in the third column, has a much more limited effect in that terms. So my preferred, of course, is reconstructing the fascia lata, because it seems to be the primary restraint to this internal rotation. This is exactly the same that Lars and Gebretsen, some 20 years before, described in this nice study. So reproducing the fascia lata graft, the modified lemur, and doing some biomechanical tests. And he was able to see that if he reconstructs the fascia lata in the lemur modified technique, they were able to reduce by 43%, almost 50%, the stress on the ACL. So again, important things. How we do it? In the past, we do a huge approach, and this is the lemur on the left side. Then we move to the Arnold Cocker technique, and then more recently to the modified lemur that is pretty much the same. Here you can see a technique they call monoloop. My friends from Belgium call monoloop. We do a very small approach on 5 centimeters over the lateral femoral condyle. We undermine the skin. We harvest a graft of 1 centimeter, a strip of 1 centimeter of the fascia lata, 9 centimeters in length. Then we free it and coagulate cautiously, particularly the superior external geniculate artery, because it tends to bleed and provoke here a huge hematoma. We put any kind of stitches at the end. We size this graft, and then we pass underneath the lateral collateral. This is the main difference between the modified lemur and the ALL reconstruction. And at the end, we fix it in the so-called Coca point, that is the same point that Ken Krakoff, some 30 years ago, described as the most isometric when doing this kind of repair. So again, nothing new. This is the point, and well, the way we do it, we fix it under the collateral, and then in this point, some half a centimeter proximal and half centimeter posterior to the femoral epicondyle. So what are the current role of this lateral tenodesis? We just studied 3 scenarios. One is the primary ACL reconstruction, the other one is the ACL revision, the third one is, in general, the rotatory instability. Let's see the first. In the primary ACL reconstruction, we have a couple of old studies, both of them coming from the Rizzoli Institution in Italy. One is a longitudinal series, the other one is a prospective randomized control trial. And what they have seen in the first study is there are good functional outcome, good IKDC, and only 20% of the cases progress to osteoarthritis after some 10 years of follow-up. In the randomized control trial, they see that when they compare the 4 strands of hamstrings against the BTB, of course the hamstrings plus the lateral tenodesis, they see better stability, better AKDC, and better return to sports. Much more studies, they exactly refer the same reduction in pivot sheath and no difference in clinical outcomes over time. This is from our group, and we see particularly what happens in the younger population, in children. And this nice study is part of the PhD of my colleague, Simone Perelli. They see that if they use this technique in children, the amount of reduction of the pivot sheath and the amount of stability of the knee and the amount of the lower retir tear is better when you use the lateral articular tenodesis added to the reconstruction, to the conventional reconstruction. What happens in revision? Again, we have some literature. This is the first study probably from my friend Philippe Colombet. They look at 20 ACL revisions, 20 ACL failures, and they navigate, when the navigation was in shape, they navigate these cases, and he was able to see that if he used navigation, he was able to get a similar antibial translation, but less internal rotation and 90 degrees of flexion. So the technique is efficient doing this kind of reconstruction in reducing the pivot sheath. This is a clinical study from the French group, from the French the Société Française d'Arthroscopie. They see that after 10 years of period of follow-up in this multi-center study in 10 hospitals, minimum 2 years of follow-up, maximum 10 years, ACL revision with or without tenodesis. When they add tenodesis, they have less pivot shift, 80% versus 63%. They got less failures, 70% to 15%, almost half of the series, and similar EKDC, if the things goes well. And more recent, this systematic review, 800 plus patients, 4.9 years of follow-up, ACL revision plus LAT, pivot shift was reduced in 80% of the cases, return to play in 75%, and failure rate just 3.6. That for a revision is really a low ratio. Rotatory instability, this is the last point. Probably the most concerning point in our daily practice is the cases with transtibial technique that doesn't do well. And you know, transtibial technique was developed to avoid impingement with the roof of the intercondylar notch. At that end, they put the tibial tunnel far posterior, and consequently, the femoral tunnel was a little bit anterior and high in the notch. So they had this type of reconstruction that was able to control a little bit the AP motion that looks really nice at arthroscopy because the biology is good. Probably is a ligament with a bit of stress and looks very well, but the biomechanics is bad in controlling the rotational stability. In our case, in these cases, when they have not high demand, they are young people still active, and we have a room high enough, we used to have a second ACL, much more anatomic. But when we face a knee with a small intercondylar notch, when there is no way to put another ligament, instead of removing the former one that is not perfect but not bad, we just do a lateral tenodesis. We did some investigation on that, and again, what we found is that when we use this technique, the results were really nice. We compare it in patients, and besides of that, we studied in patients with more than 60 years of age, or 55. In that case, we put 55 at the limit. In patients that they have an ACL instability, but are older enough not to do a conventional ACL because of the long time of rehabilitation, and or when we have a first step in the revision case when we cannot do the full revision at the same time. So what we found in those cases is that, again, this is our data, the things are comparable, under anesthesia, pre and post-op, and at follow-up, pre and post-op, what we have seen is that technique is efficient in controlling the AP motion, and these patients, most of them are happy, even those that are in the way of having a second surgery. Some of the cases, they, well, doctor, I am okay. I don't need the full ACL reconstruction because with that small technique, I do very well. Finally, there are some warning. No, there is no technique perfect. And what we have seen is that applying this technique at the 10 months follow-up, the maturation of the graft that has been related to the degree of strength of the graft itself is not perfect when using a lateral tenodesis, as it looks at the MRI, using this signal-to-noise quotient, meaning that probably if you do a lateral tenodesis added to the ACL, and that's to answer your question, Enrique, probably we have to be careful because the patient feels very stable, but the graft maturates a little bit slower than when there is no added lateral tenodesis. We don't know if this is a good fact or a bad fact, but at least it's a warning to be taken into account that according to the MRI, the maturation is slower than in the isolated ACL reconstruction. So the current evidence says that the lateral statical tenodesis improve kinematics in the ACL deficient knee, reduce anterolateral rotatory laxity in ACL reconstructed knees, reduce graft rupture in young patients, and has a low retear, a low occurrence of secondary meniscus injuries. That's what we know from the literature. Therefore, The indications are not that clear, except for revision. Of course, it's mandatory to do it in revisions, in most of them, but it's still under debate in the rest of the cases, primary reconstruction. But it seems that Marcel Lemaire was a wise guy, and it's not the ugly face of this story. In my personal opinion, personal indications are like this: children, ladies are playing at top level, like this lady in our team in Barcelona, or these injuries in the bone that make us think that there is a huge instability. So in summary, ACL reconstruction plus lateral tenodesis is adequate in high persistent rotatory instability, is adequate in children, and is adequate, sure, also as stabilization, probably unique stabilization in people over 55 or over 60. Again, all of you are invited to the next ESSKA events, particularly in Warsaw in a couple of months and Milan next year. Thank you very much for your attention. Muito obrigado.
Thank you, JC. E agora vamos ouvir o meu querido amigo Henrique Jones, distinto especialista em ortopedia e em medicina desportiva, baseado no Hospital da Luz de Setúbal, diretor clínico da Clínica do Montijo, ex-presidente da SPAT, ex-presidente da secção de medicina desportiva da ESSKA, a ESMA, ex-vice-presidente do Comitê Médico da UEFA e da Sociedade Portuguesa de Medicina Desportiva. Portanto, uma pessoa com muita experiência nesse campo e a quem a ortopedia portuguesa deve muito, com certeza. Henrique, o palco é teu.
Obrigado, Helder, pelas palavras. Obrigado a todos vós por estarem aqui nesta mesa redonda. Foi-me adstrito o tema de reconstrução do LCA em crianças e adolescentes e quais são os critérios. Falar em inglês, como foi acordado, I will speak in English, just for courtesy for our guests. I have no conflict of interest in this presentation. And when we think about ACL reconstruction in children, is that a question of love? Because children have passion for sports, most of them. Or is it a rational decision-making? So when we have a child with this kind of problem, we must be rational and not take decision by our heart or affects or pressure. I just remember you that in 2022 in Portugal, there was 197,000 football players at all levels. The number of football players is increasing, and mostly in the age of 107 years. So we have an augmentation of 49% and 40% in football, traditional football and futsal. So it's an increase in practice. But for just an apart, in England there are 1,500,000 people slow age playing football in 7, 8, 10, 11 years. But from those people, those young people playing football, only 0.012 arrives to the first league. So we must be careful to deal with these children, as we see after other slides. And the fact is that the increase of ACL injury, mid-substance injury, is because of what factors? And I think, and we all that are in football and other sports modalities, we think that the early specialization and the loads are very important in this kind of injury. We know that injuries are increasing, mostly between 6 and 18 years old. We know that in 6, 7 years they begin with specialization when they should be playing football in a ludic aspect, but they are already competing, they are already doing repetitive gestures, and although we know that football and other team modalities are important for children, but I think nowadays they are abusing in this early specialization. That's why children are playing with more intensity, with more force than 10 years ago. And they are, of course, targets to several injuries, mostly ACL injuries that are growing, as we all know. And also, another problem is the lack of prevention programs. Not because people don't know they exist, but they don't put that in practice. And we should invest more in prevention. And so ACL injury in children, we must understand the problem. Is that only a medical question? No, it's not a medical question only. It's a multi-individual problem. First for the decision, then for the recovery, and finally for the return to sports. And what are involved in all this? Doctors and parents, doctors and coaches, doctors and team managers, doctors and other doctors, because everything, some doctors have different opinions from the other. And the triology of child, parents, and surgeon is not the only one. There is another things that are invested: the children talent, the parents' investment, the injury itself, the dreams falling, and the urgent decisions that must be made. And so, when we have the decision to make, what can we expect? We can expect, in the beginning, if you have a conservative treatment, a high-quality rehabilitation, non-surgical treatment, or you have ACL reconstruction plus high-quality rehabilitation. Of course, in the acute case, we can always think of a repair surgery. There are more and more works about this one. I have no experience with repair, but we can also see this kind of image. And another thing, if conservative treatment fails, because children that symptomatic recurrent giving way, or because the children have another associated injuries like meniscal injuries or cartilage injuries, or if the children is absolutely non-acceptable with the restrictions to his new kind of movement, new kind of sports. So in that case, our concerns must be about surgery and what kind of surgery. Of course, there are most important considerations when making these treatment decisions. The decision for ACL reconstruction, the skeletal age assessment, Turner stages and bone ages, risks associated with ACL reconstruction itself, management of associated injuries. But if we decided to make that kind of surgery, we must be aware of all techniques that we can make around. Just, of course, to avoid things like that, not for ACL, for a condyle fracture, and this boy was playing football normally, and nobody says to him that it could be very dangerous to still going on playing. What is consensual about this topic? Bony avulsions of the anterior cruciate ligament requires surgery as soon as possible and must be, of course, anatomically restored. This is a case of my friend and colleague Manuel, and this kind of injuries must be, of course, immediately repaired, as this is the normal appearance in ACL children injury. But now, 10 years after, what we see is not this. We see really mid-substance ACL injuries. So when we think about ACL reconstruction in children and adolescents, what should we expect? In first time, we must have what literature support us and the support that literature gives to us. And we know that returning to pivoting sports in children that have surgery are 3 times more frequent than in non-surgical. At the same time, the risks of those non-surgical approaches is much more increasing regarding meniscus and cartilage defects. So we must put in our balance what should be the future of these meniscus and cartilage and what should be the sports future of these young people. What is consensual about the topic? It's consensual that partial tears of the ACL in this age group should normally be treated without surgery unless a severe pathologicity is present. We know that post-pubertal patients who are nearing skeletal maturity could be treated as adults. We know that in this near close to physis, we can have some more caution. We can centrally place transphysial drill holes. We can avoid dissection near the physis or fixation devices near the physis. Soft tissue grafts should be preferable. Bone blocks is to avoid, and all associated injuries must be treated carefully. And of course, monitoring this kind of athletes because of what could be the future regarding the axis of the growth of his lower limbs. So, the decisions is regarding anatomic techniques transphysial or non-anatomic techniques physical sparing or partial transphysial. All have advantage and disadvantages, but it's all kind of other questions that we must have in mind. ACL reconstruction all inside or not, combine ACL with ALL reconstruction or ALL repair using living donor hamstrings. I have no experience on this. Use PRP in the plastic on inside tunnels. We all know from some papers that PRP works very well in children. Remand preservation, like you see here, should we maintain the remaining ACL? Use brace in children. There are some questions that we can discuss at the end. But we all agree that complete ACL tears in young athlete, if prepubescent with this age, physio sparing ACL reconstruction should be the rule. With physio respecting ACL reconstruction, if they are between 12 and 14 girls or 13, 16 boys, and close to the physios, we can do it as an adult transphysial ACL reconstruction. You see here in the figure, in the image, using a physio sparing ACL reconstruction using over-the-top technique, which could be an option in this kind of injuries using iliotibial band. But what is my criteria regarding this? We know that if you have an X-ray or MRI with anterior tibial spine fractures, Myers and Kivers 2, 3, or 4, surgery is the rule. If you have a complete ACL tears, children under 10 years old, no meniscal injury, no significant laxity or other symptoms, psychological with good balance, good parents, good environment, occasional sports, so conservative treatment, delay surgery program until near also maturity, but only if these conditions are present. Surveillance, physical exercise adaptation, brace, discussing or not, but wait until they are near osseous maturity. What about more aged children, like 3 years old in girls or 4 years old in boys, tenor 1-2 meniscal injury, significant patholaxity, regular intense sports, meniscal structure, of course, ACL physical sparing or partial total transphysial, caution surgery, and if they are over 13 years old in girls and 14 years old in boys, I do it like an adult surgery. So, near osseous maturity, we preferentially recommended surgery as it's done in adults with some special cares. We prefer arm strings. We use single bundle anatomy, semitendinous, gracilis, or semitendinous alone. We made tibial tunnel more central and vertical, about 60 degrees. We perform 7 to 8 millimeters diameter tunnels, preferentially 8 millimeters. We use low-speed drilling. We fix with cortical devices in femur and non-observable PIC screw in tibia. We have no experience with living donor hamstring and allografts, and we consider each more in children and adolescents ALL reconstruction lateral extra-articular tenodesis. But the facts are that pediatric patients who underwent ACL reconstruction have a high risk of a rupture, about 32%. Because adolescents have a revision rate that is high. And why? Because there are some facts that sometimes we don't think about. It's that an interarticular hamstring's graft diameter has previously been shown to decrease with continuing growth of the knee. So we don't have the same diameter that we have been initially. The other thing is the graft remodel faster than in adults. And that's why we see our children trying at 1-2 months, as we will see, trying to say, I'm okay, because also the remodulation are faster. And another thing, in the group that are non-surgical at the beginning, they are 1 to 3 years waiting for activity, waiting for gestuality, and that's the conditions, the muscle and tendon condition decrease. And finally, they try to return to sports sooner in time and more intensive in activity. And this could justify this kind of risks of rupture. Juan Carlos already spoke about the extra-articular lateral tenodesis combined in pediatric patients with ACL reconstruction. And there is some papers that really show us decrease in numbers of failures of the reconstruction. So more and more we think that this is one area where the anterolateral ligament reconstruction should be seen as a worst value for the future of this kind of surgery. And finally, what about rehabilitation? Accelerated protocols are not for children or adolescents. Rehabilitation before puberty can be a challenge and implicates ludic and motivation process. So you must speak with your physio and try to alert with these facts. Physical spare techniques, no height bearing until 5 to 6 weeks. No braces during rehabilitation, but more and more in some specific cases, I think we can think about braces. Proprioceptive bearing allowed since the first day, and transphysial techniques, no height bearing until 2 to 3 weeks. And then the habitual procedures of rehabilitation, muscle strength, range of motion, pull exercise, proprioceptivity, and after week 12, the plyometric and all the other increased exercises. So the great challenge, to finalize, is break the enthusiasm of these children. You see this is a 30-year-old gymnastic athlete with condition to Olympics. He made an ACL injury. He was operator, tenacity near osseous maturity. But after 1 month, she is like this. Full range of motion, no effusion, no pain, and he said to you, I want to go make my gym. And here is our time to break the enthusiasm, to explain the whole evolution of the process. And the process should be the milestone progression. If you have this goal, you can go to another phases. And this is done by phases. Because if you see, if you have a good ACL reconstruction in his ages, this guy is 15 years old, top-level competition in gymnastics, return to sport after 10 months after surgery, but the 10 months are not the target. The target is to run with all the phases that are controlled one by one. But in the end, the most important is prevention. And we all are fighting now for ACL prevention, because talents like this needs protection and needs prevention, not only the value in several millions. And that's why we create, with Thomas and Pascal, we create a prevention program in children and adolescents that we can see in ESSKA Academy, and we are all days fighting for prevention. And finally, the take-home message: ACL injuries in skeletal immature children means each time more a frequent challenge for us surgeons. Prevention programs should be introduced sooner in childhood participation. Several questions must be analyzed between child, parents, and surgeon in each particular case. Operative treatment should be mandatory in bone avulsions and when associated with another injuries. Failure of non-operative treatment would implicate, of course, surgical management with several techniques that we must dominate. Graft choice, transphysial or physical sparing techniques, and the possibility of need of lateral extraarticular tenodesis should be discussed and documented. Rehabilitation after surgery could be age-specific for each procedure. Knee brace after surgery can take into account according with the individual approach. I don't like braces for my ACLs, but in some cases I can agree that it could be a worst value. And we should follow these children very straight, because they are always running to our ideas and our recommendations. Thank you very much, and see you in specialty days in Warsaw. Thank you.
Thank you so much. Thank you so much, Enrique, for this brilliant talk. And last but not least, Thomas Pat, coming from the Netherlands and also visiting consulting surgeon in Kuwait. Vice Chair of ESMA section for ESSKA, and also member of the ACL study group. And thank you so much, Pat, for cooperating together with Enrique and Pascal in such a wonderful project of ACL prevention from the ESSKA team. Congratulations, both of you.
Well, thank you very much for the nice invitation. And just a small word to you, Enrique. You said a word which is very important. We have to break the enthusiasm of the patient. And that is the worst problem we're having, because otherwise down the road they're going to have huge problems. So we've been on the medial side, we've been on the lateral side, we've been at the front, and now we go into the back, and this is the posterior cruciate ligament. So thank you for the invitation, Enrique. The PCL is the strongest ligament of the knee, and the primary function is to resist posterior displacement of the tibia in relation to the femur, whereas the secondary function is to prevent hyperextension and limit internal rotation, predominantly, especially between 90 and 120 degrees. So when we look at the anatomy, we see this is a bit complex, and what's not here, of course, on those cadavers is you have a very important artery just 4 to 5 millimeters behind it. Okay, so be aware that here, this is a bit danger zone, which makes it fun, but which to me is very important. I do those surgeries with a colleague with me at the OR, because you need that extra hand, and that extra hand sometimes really is extremely important. Okay, so we have two bundles, a large anterolateral and a smaller posteromedial. So the posteromedial bundle has shorter fibers, is tight in extension, and is main resistant between 0 to 15 degrees of flexion, whereas the more important anterolateral bundle is the thickest in diameter, has the longest fibers, is tight with knee flexion, and the main resistance between 70 and 105 degrees to posterior tibial translation. And we also have two small other ligaments, the meniscofemoral ligaments, the Humphrey and Risberg, and they commonly remain intact if you have an ACL rupture, and they give at least a little bit stability. So if you look at the biomechanics, the PCL is a non-isometric structure. The length increases as it flexes from 0 to 90 degrees, and it remains relatively constant between 105 and 120 degrees, whereas it decreases if you go above. Again, this is a bit more complicated than an ACL. The problem is to have a good look at it. And here on the cadaver, you can see it quite clearly, but in real life, that's a little bit difficult. So the strongest bundle is the anterolateral bundle. And there are studies reported near normal knee kinematics when only the posterior medial bundle was sectioned, which means that the anterolateral bundle maybe is the only one that should be restored. Again, the anatomy. So what is the mechanism of a PCL rupture? It can become injured from a direct blow, so you all know it, it's a dashboard injury, or it might be when they drive on the motorbikes, on the scooter, or if you fall on your bended knees. And usually when the patient talks to you and you listen carefully, then you know already, okay, we have to be prepared for the PCL, because the PCL sometimes is difficult to diagnose. Talking about this, you have the posterior draw and you have the posterior sac sign, which is good to see if you look for it. And as you can see on the lower left, sometimes you think it might be an ACL, but it's not, because the ACL is intact, but it seems loose because it's going more to the back. On the MRI, usually it's clearly seen, so I think that's a very important mean to use. In all my knee patients, I do use an MRI, so I think that is important. So if you look at the incidence comparing to an ACL, this is much less. 90% have a symptomatic PCL tear, also have something else. Whereas the incidence of isolated PCL reconstruction is approximately 10% of the total which is performed. And only 2 out of 100,000 have a PCL. In the presentation that comes later on, we're going to talk about that from the ACL. This is a totally different thing. And what's going to happen later on? You are looking for patellofemoral problems in the chronic case, and you can also sometimes see on the medial side, the medial compartment, with more pressure due to a PCL. But the main problem is a long-term problem, not the acute one. So there are different tears. The grade 1, the grade 2, usually conservative treatment is enough. The grade 3, or what I write here down, the grade 4, you have to be careful because that is much more, but these are more easy to diagnose. And if you have a posterior translation above 12 millimeter, usually that's not only a PCL. So if you talk about indications, a grade 3 might be a good indication. A grade 2 or a grade 1 usually is not. So what I explain to the patient, so if you have the upper leg and you have the lower leg, and when you lay down, it's like this. And when you do surgery, well, this is a grade 1, 2, 3. So if you have a 3 and you put it here, gravity will bring you later on a grade 1 probably. the result is not as excellent from surgery as we have with the ACL. So you have to be careful. And if you have a grade 1 or 2, usually the complaints are so minor, so you wouldn't need surgery. Combined reconstructions for multi-ligament lesions are important. If you can repair the meniscus, of course, you have to do it. If there is a bony avulsion, of course, it's something that you want to do and take care of very soon. But look out for the chronic symptomatic PCL tears, because they might give the patient problems down the road. So this is a possibility how to look at it. So on the left side, you have the tibial avulsion fracture, of course, that needs probably some treatment, especially if it's a large fragment. But if you look at the isolated PCL and you have a grade 1 or grade 2, it's much better not to operate because the patient won't have any problems. With a grade 3, it depends a bit on the patient itself. If it's an athlete, of course you will do it. If it's a non-athlete, you might even then try conservative treatment. If there's a combined ligament injury, more has to be done. Now, you could also think about single bundle or double bundle, and there's a lot of literature around there. But the question is, what is really better? And to me personally, double bundle is double trouble. And I think if you only do the anterolateral bundle, then I think you're going quite good. But the literature shows there are good results. On the other hand, they show it doesn't really matter whether you do this one or the other one. One comes closer to the native ligament, but is it about the naked ligament or is it about complaints of the patients? So very important is anatomical restoration, and of course look for the kinematics. So we are a private clinic chain, and in our clinic we did between January 13 and 21, 61 patients for the PCL reconstruction, single bundle. Follow-up was at least 25 months, mean age was 28 years. And when you look between pre-operative and post-operative on the IKDC, 95% were A and B. Yeah, and also if you look only at the grade A, it's 72%. This is quite a good result. The TEGNA went from pre-injury 6.7, pre-operative 3.5 to 6.1, which is quite good. And also the LISALM improved. That's on the single bundle. In the other clinic, they did the double bundle. And they had 15 patients, aged 18 to 84 years, and they have even better results if you look at the IKDC, because they have no C score in this, and 93% already in A. Regarding the TEGNA score, from 3.8 to 6.6 later on, this is quite good, but that's comparable to the single bundle. So what I'm doing the single bundle, but I use that extra tape. And I use it especially in order to prevent what I just said. So you have that 3, and you lift it up again. And sometimes gravity brings it back down, but the extra bundle, the fiber tape in this case, is helping quite good. And actually you can rehabilitate, you can walk on it much easier and sooner. So here are some pictures, of course. On the upper left, you see an ACL that seems to be a little bit loose, but it's not, because the PCL is on the back side. Then on the upper right, be very careful, and that's why I do love this instrument, the flip cutter, because you can do retro drilling on the tibia, which can be visualized very good. And it doesn't bring you all that debris into the knee, but just the other way. On the lower left, you see the button deployment that can be seen on the medial side. I'm going to show that in a minute. Just a couple of days ago, we submitted this, which will hopefully be published in the Journal of Arthroscopy. And that's something that Bertrand and me talked about it at the Isokinetic in London. I said, are you doing that also? And he said, yes, I'm doing that also. I said, okay, let's try to write something. And he had that publication on visualization of the button on the femur. And I had the same, but he was first, so that's good. But now on the PCL, we did that. So here again is the test. But what you can do with this technique, in case you use that technique, what is really nice, so you have the extended, almost extended leg, and you can see there with the outside, with the inside-out drilling, you can see where it gets in. And actually you can see where the button is in the medial gutter without any extra portal, and that gives you just much more safety to me. I use it in ACL and I use it now also in PCL. That gives you much more safety in later on knowing the button is on the right place, plus there's nothing in between. So that's one step. And if you bring in the transplant, you can follow it with a scope and see how the button deploys. And that is very nice every time with the PCL as well with the ACL. So when you talk about return to sport, again, the incidence is very low for the whole injury. I'm going with Robert Laprade, who says as it's more complicated surgery, the rehabilitation has to be slowed down. Whether you use a brace or not a brace, to me it doesn't matter, as I use that extra tape, intra-articular, but I know that a lot of people do use it, and there's nothing wrong with the brace. But take the time, and the most important thing is, and I think we all say that to the patients, it's a longer rehabilitation, and it's going to take 9 to 12 months, if not more, before they can go back to the field. So, in summary, it's a rare lesion, it's often misdiagnosed, and the incidence is very low. The classic trauma, dashboard, hyperextension, bended knee or scooter accident, often in combination with additional lesions. Conservative treatment plays a much bigger role than with the ACL, and operative treatment has a long rehabilitation and really needs specialized physiotherapist. Thank you so much.
Então, perguntas da audiência. Well, one. Okay.
Hello, good afternoon. To Dr. Carlos Monlau, you said ACL maturation is delayed with the lateral tenodesis. So you delayed the return to sports when you do lateral tenodesis?
Good question. Really, no. We just discovered it. It was by chance. We are looking for another thing. We just want to see how the maturation process is. And what we realize is that when using lateral tenodesis, the maturation process is constantly much more lengthy than with the isolated ACL. What does it mean? It's not that clear. Probably it means that the graft is so protected by the lateral tenodesis that the maturation process takes longer. But this is not specifically bad. Probably even is good. However, it's a warning, and we have to say that we are assuming that the signal on MRI equalizes or means that the graft maturation is at a definite moment based on previous literature. But probably is not exactly like this, but that is our assumption. We are not changing our protocol right now.
I also had a question for Dr. Monlau. Thank you, everyone, for your talks and for coming. So for your LETs, I trained with Andy Williams, so I have very similar indications for your LETs. I've also been recently doing what you suggested, of doing an isolated LET in these patients with these vertical-ish ACLs that aren't completely out of the way, but they're not in the right spot. But I don't know if that's the right answer. I've done about 8 or 9 of them now, and I've told them this may last a year, it may last 2 years, it may last the rest of your life. Do you have any long-term follow-up, any medium-term follow-up? Because I'd be very curious what your experience has been with this.
We just published a series on that. Well, the thing is that most of the transtibial techniques do well. That's a fact. But some of them are not that good. In those cases, there are 2 possibilities. The patient is high demand or the patient is low demand. If it's low demand, probably nothing happens. It is a patient of high demand, needs something else. In this regard, we developed an arthroscopy, we scope the knee, and if the notch is large enough, we build another ACL. If the arch is really small, we prefer the lateral tenodesis. We have seen no differences in a small series of cases doing this. I don't know the definite answer, but seems to work.
I would have a question. For me? Yes. So, in how many degrees do you fixate the LET?
That's a very good question. At the beginning, when I was young, we used to do the large lemur with a big approach, and we fix it at 90 degrees of flexion and in full external rotation. Then, because of the concern raised on the overconstriction of the lateral compartment, we moved to a neutral position, but in 90 degrees of flexion. And at the end, we thought, well, if what we aim to control is the pivot shift, and the pivot shift happens between 0 and 30 degrees, probably it makes sense fixing it at 30 degrees. And that's exactly what we are doing right now. So we fix it in neutral rotation at 30 degrees of flexion.
JC, before leaving you alone, I also have a question for you. You mentioned that you were using the Arnold Cocker modification, which is somewhat appealing, low cost, easy in immature, and then you came back to the why?
That's a good question.
Because we have seen recent publications favor.
It's the story on my hospital. We have a friend, we were taught by him doing the lemur. That was a really extensive approach. And when I was in America with Dick Stedman, in some cases, he used the Arnold Cocker technique. That means a very less aggressive approach. And I love this technique. So I changed to the lemur, to the Arnold Cocker. But then, particularly some ladies complain about having some bulky feeling here. Is that okay? Bulky? And, well, then our friends of Belgium developed the monoloop. That is a modified lemur that is less bulky because it's much more anatomic, and, well, we do it. But the results is pretty much the same. We have reviewed our Arnold Cocker. We didn't publish it, but we review the technique, and it's pretty much the same.
We also have the small bump every now and then, but besides that, we don't. And the risk of confluence of tunnels, sometimes with concomitant ACL,
yeah.
And in the immature population.
You have to look well to the so-called Coga point, and then angulate your lateral tenodesis on 30 degrees, proximal 30 degrees
but it's blah, blah,
anterior,
blah,
and that's it. Yeah.
Well, Juan Carlos, one of the indications for lateral S-articular tenodesis is residual pivot shift and some kind of internal rotation. Don't you think that sometimes this pivotage or this instability in internal rotatory is because a root or a ramp lesion of internal meniscus is misdiagnosed and mistreated?
Sure. Some of our fellows call the medial meniscus ramp the fifth ligament because it's really a constraint in AP motion, uneven interval rotation. So yeah, sure. But I think it's a constellation of things. It's not just the lateral tenodesis. It's the anatomy of the joint, the dimensions of the notch, the inclination of the TBL in the sagittal view, and there are so many things. But lateral tenodesis can contribute in chronic cases or when we have more than the laxity expected after having the ACL torn. Of course, it contributes to constrain the knee and to have better results. Yeah.
Like Jon wrote maybe 12 years ago on an editorial, it's ACL reconstruction, it's a la carte surgery.
Talking about rotatory instability, I think this applies perfectly to the PCL reconstruction, because you are talking about the isolated PCL, but this is probably the tip of the iceberg. I mean, most of the cases combine some kind of lateral problems or medial problems. How do you approach it?
There's a question there. Please. There's a question. Marco, please.
While we wait, you see that it's the same with the MCL. Most of them we are treating it in combined injuries. We not that often treat isolated MCL.
Thank you for all of your brilliant talks. I have this question about the ramp lesions, which they may be considered the fifth ligament. In a practical way, we know, and there is some publications on it, saying that some are hidden. You go, you scope through the notch, and you shoot the bride a little bit with the needle to make sure if it's there. And maybe if you don't do it, we're missing between 15 to 20% of ramp lesions. Personally, when I reach the posterior aspect of the knee, if it looks great, I don't touch it. It makes lesser effusion from the fluid outside. But my question is, how many of you systematically debride the posterior aspect of the meniscus to make sure there isn't a ramp lesion?
No.
No, I don't do it. And on top of that, if I do, maybe this is open to criticism, but I will share. If in my pre-op planning I find a ramp and I go for a posterior approach, I don't reopen, I don't recreate the ramp, I just suture it. I know it's there, I pick up the tissue, and because it has healing potential, we are on the periphery, and in my sense it doesn't make a lot of sense to create more arm and then repair the arm that I've caused. I don't know if this adds something to your question.
Well, from the level 5 now, huh? But I do just the same, because otherwise you create a ramp lesion, and then that is a ramp. So.
Yeah, but many people defend that you should explore. If in my pre-op it's identified, I will go and treat it. If I am in doubt, then I will explore if there is opening, laxity, from the front and from the posteromedial view.
Yes.
Yes, please.
Yes, sorry. I also had a question for the MCL talk. I think you nailed what I think is a very difficult algorithm for when we should fix MCLs. I think it's good that we're talking about MCLs now and at least acknowledging the frequency in which they're injured with the ACL. My question was specifically about that ACL isolated deep MCL avulsion, which if you start looking at your ACL MRIs, you will see all the time, especially in soccer players. That's their mechanism of injury. The question is, when do you fix the deep MCL? And I'll tell you what I used to do, and I'll tell you why I don't know what to do anymore, is I used to use the Slocum test and check for that increased rotary instability intraoperatively. And it took me about 9 months to figure out I only got a positive Slocum when there was a ramp lesion also involved with the deep MCL.
You got to the point.
So if I fix the ramp, is that good enough? Or should we fix the deep MCL and the ramp? I don't know what to do.
I don't have an answer to your question because I don't have the evidence supporting it. And this is a nice study, because for me it brings attention for the relevance of identifying the ramp lesions that are hidden in this sense. We know that the main restraint to valgus will be the superficial, but in this case, the fact that this deep MCL injury is hidden combined with this ACL brings you attention for the possibility of a ramp lesion also occurring there. And then you make your posterior medial portal and you do the assessment from the front and from the back to check posterior medial meniscus stability, and repair the ramp if it's there, and leave the MCL. I've never reconstructed deep MCL in this setting.
Yep, I fully agree on that. But what I would like to point out is that if you have an ACL TOR, you have an increase in internal rotation of the tibia. If you have deep MCL TOR, you have an increase in external rotation of the tibia. This is contradictory. And if you have a RAM lesion, you have an increase in AP motion, basically. So probably you have to individualize and treat every single injury. However, to be honest, I operate in my life, I think 3 cases of deep MCL, chronic cases because of persistent pain here. And I just repair the deeper portion of the MCL. And in general, in acute lesions, all them heal, or at least in my experience.
Yeah, that's the point. That in my hands, the daily practice is exactly what you stated. It's different on the chronics, because then you have a different issue.
Good evening for everyone. Thank you for the lessons. I'd like to ask, especially for Dr. Pat, please, if there is any room for inlay reconstruction for PCL, and to the others from the board as well, please.
Excuse me, could you repeat it, because I hear bad?
Oh, if there is any room for reconstruction with inlay technique in PCL.
In my personal experience, not. We talked today about it already, so I have to pass it to the gentleman. I'm not doing any trauma, so therefore, no. But, gentlemen?
Well, I did it 20 years ago. We don't have many PCLs, yeah? We operate 100 or ACLs, but 1, 2, 3 a year. But when I begin as a resident, I became doing that with my master on lay. And I should tell you 2 things. First, I learned a lot of anatomy, and then the results were much better. At last is what we feel with the evolution of the patients. Because you don't have the problem of the vessels, you don't have the fear of the vessels, you don't have the stress of the tunnels and everything. You put there and you can restore much more anatomically. Nowadays I don't do that, because someone will call me an old man. I do it.
Yeah, but there is
there is good results with one lay technique, yeah?
I don't do it also, but you won't find evidence stating that if you are doing an inlay anatomic reconstruction of your PCL, you are doing something wrong. In the group of Philippe Neyret, we did a study and with comparison with control groups, inlay versus arthroscopic. The graphs were also different, so there is also a bias. But still, today, despite all the things you can do inlay, there is also a Brazilian group publishing on a big series of inlay reconstructions, and there is no evidence that it's systematically better.
One thing is for sure, you are much more confident about the killer angle and the turn angle, because you can do it much more smooth. And when you leave the surgery, you can be confident that that angle is not conflicting in the future. So it's easier in that way, and it's the only thing, because sometimes, even with best techniques, we are always afraid of the killer turns.
And another topic that Pat opened the window, Tom opened the window a little bit, is many in our country, many of the PCL reconstructions we are performing are in multi-leg injuries, and it's much easier surgery if you do everything from the front and you take an hour or an hour and so to do whatever, and then to have the patient prone, then supine and all that. But Tom, your idea?
Well, no, I agree absolutely. So the technique I'm using, because I try to see the patient as few as possible, okay? And yeah, no, it's honestly, and I tell the patient, you want one thing and not meet me again. I do love, and even that's from special industry, but I do love the flip cutter. The flip cutter, you can see, it's a 3.5 drill. So you have enough space if you later on have to drill an 8 or a 9 millimeter tunnel. You take all the debris into the bone. The vision is good. So that helps me a lot. Okay, that really was an eye-opener for me. And if it's only for that surgery, for the PCL, please do try that retro drill, because this is really excellent. Then talking about the killer angle, to me that is ancient. We're talking about what, a killer angle? I don't think it's there, because we can see it now, even with the scope, with the posteromedial or maybe also posterolateral portal, you can see it if you position the patient good. Because I mean, if you talk about this kind of surgery, it's all about very minor details. Yeah, so the positioning has to be excellent. Then the anterolateral, anteromedial portal, which height do you use? That is so much more important than with a normal scope or an ACL. And then in former times, we used the quadriceps or the patella tendon. And now we're talking about a flat tendon, right? So the flat tendon, and then if you have a sharp angle, yes, then I think then you saw more problems with that, but now using more hamstrings, you have a rounder, and you have more, actually, in the diameter, you have more ligament, and I think, therefore, that word killer angle really is ancient and should stay there. Don't you think?
That's important. That's important. The flat of the plasty that we have with the bone, patellar bone, are much more prone to the cutter angle than the hamstrings, no doubt for that. But the problem is that it's always something running out from a tunnel, different from something that is put and have much more space.
Well, let's put it this way. The danger zone is that it's somewhere in the dark in the back where you can hardly see it. When you have multi-ligament things and everything is really out of bounds. So leave it in hands of someone who does it often. There are a lot of things I do not do because I know others are better. And actually it's on the patient, and this is not about, oh, how good I am, how cool am I to do so. No. The most important thing is when not to operate. And so I think that's the most important. And if you see that the incidence is so low, just keep it so.
Mais algumas questões?
So now we have 20 minutes of break before we start a great session.
Sorry, Pat, I'm the moderator. I must finish.
How did you guys manage to build up the prevention program?
Bom, obrigado a todos por terem ficado para esta sessão. Thank you very much for the... after this session, we have invited lecture by Juan Carlos and Thomas Pat. I think it will be interesting for you, even if the hour is not the best one. But again, obrigado pela presença e pelas questões pertinentes que puseram. Muito obrigado.